CPD approved. It is now. If you're not happy for it to be recorded, we ask you to leave the meeting. Sounds a bit rough. This webinar is CPD approved, and Jana, our administrator, on request, and you should have her email, will send you CPD certificates. So now it's my great pleasure to present Kathryn, our presenter, Kathryn Mannix. Kathryn is consultant in palliative care in Newcastle. She qualified as a doctor in the early 80s, and since 1986 she's worked in palliative care. She's also a cognitive behavioural therapist, and she launched the first UK dedicated CBT palliative care clinic. She's also the author of an acclaimed book on how to live and die well, which, as an Observer critic says, is of heart-wrenching testimonies to human courage and love. I'll hand over to Kathryn now.
Thank you very much, and good evening, everybody. I'm sorry that we all have to leave our cameras off apart from the panel. And those of you who still have your cameras on, we have to ask you to do that. It's partly because my mobile phone signal is so poor that I've already changed rooms once in order to make sure that we could all meet each other tonight. So it means I can't see your smiling faces. I can't hear whether you laugh at my jokes, and it feels a bit lonely broadcasting to you from my bedroom, but we'll do our best. Thank you so much for inviting me. This is an enormous honor. I'm a great fan of Marie Curie. I'm a former employee of Marie Curie, and they have been enormous supporters of my campaign to try to improve public understanding of dying. And that's kind of what we're going to talk to each other about this evening, because I think that what I feel very passionate about is that we've forgotten as a nation what dying looks like, and we're no longer well able to recognize it. And I think that that really matters, and that we need to start to talk about it. So I'm going to talk to you about why does it matter, and how should we talk about dying. So, oh, my slides are not advancing. This is awkward. Let's see what happens if I do this. Yeah, there's, okay. So in honor of full disclosure, as Bridget has already mentioned, I did write a book, and I did the best that I could. I'm not a writer, I'm a doctor. And I wanted to tell the stories of ordinary people dying ordinary deaths, because we get extraordinary people dying extraordinary deaths in most depictions, particularly on screen. And, you know, I thought it would be competent, and I thought it would get into a few libraries. I just was not at all prepared for what happened next, because people just got in touch with me. Hundreds and hundreds of people found different creative ways to get in touch through social media. They wrote to me, they found my email address, they spoke to friends of friends of friends to get to me, they contacted me through magazines and newspapers that had interviewed me about the book, they contacted me through my publisher and through my agent, and there's a sentence I never ever thought I'd hear myself say. And the messages were really, really consistent. The messages were about how people had not understood what was happening as a person that they loved was dying. And what they said was, why didn't anybody tell me? Why didn't anybody tell us what happens as dying progresses? We didn't realize it was a pattern. We didn't realize that you could talk about it as it was happening. Why didn't anybody explain that he was so sick that he might die? Why didn't anybody come to us when he was making those funny breathing noises and explain that that wasn't suffering? Why didn't anybody say it was okay to bring the children in and they wouldn't be brutalized by what they experienced? Why didn't anybody explain the noises? Why did nobody say there were choices about where she was looked after and how she was looked after? Why didn't anybody say to us, don't go home, she's so close to death you might miss it? Why did they let us leave? The consistency has been remarkable and heartbreaking. And I think that even though I thought we were doing dying quite well, this is a resounding vote for we could do better. So let's think about what the wisdom is that my grandparents had. My grandmother, who was born at the turn of the 20th century, so we always knew her age because she was the same age as the year. She was familiar with dying and death and the patterns of the deathbed because she looked after people who were dying at home because there wasn't another place for them to go to die. And dying was a thing that happened once you started to die. It was rare that there was a treatment that would stop that from happening. But as the 20th century moved forward and we got better at saving lives, and we made some remarkable advances in medical care over the 20th century, we moved death from home to hospital. So she had nursed her parents, her husband died, one of her 5 children died. And then the National Health Service happened, the advances happened. And so when she was dying, not around her life expectancy at birth, which was just short of 50 years old, but just short of her 98th birthday, she realized that her children had no idea what to expect. Now in their 60s and 70s, they had not had another close relative die over the rest of their lives. In a single generation, Britain forgot what dying looked like. And people want to know, this is the wisdom that we've lost. What is it that happens? Will it be painful for this person that I love? And if it is painful, what are you going to do about it? Will my family see something that is dreadful for them? And all of us who work in palliative care recognize that interesting change in people approaching death, which becomes very outwardly focused on the experience that their treasured people will have, far more than on their own experience. But also, will I suffer? And how will you help me if I'm suffering? Who will be there to support me? Will I be a burden? Will I exhaust my family? Who will say what I want? Who will protect my interests? Do I have choices? How do I express them? Can I express them in advance? These are all things that people worry about, need to know, and all of us listening, joining in this webinar tonight, know about how to have these conversations with people. It's absolutely vital that we restore this wisdom back to people. It shouldn't be medical wisdom and nursing wisdom, it should be common wisdom. To do that, we need an end-of-life care workforce that is fit, that is trained for this. And when you think about training outcomes, you think about them under the headings of knowledge, skills, and attitudes. So let's think about, what does the end-of-life care workforce need? And to start off, I think I should make it clear that I think that we're all the end-of-life care workforce, every member, every citizen. Because actually this isn't about medicine and nursing and physiotherapy and speech and language therapy and social care. This is about people and human beings and being able to support each other as we approach something that is probably one of the most important and certainly the only single thing that will happen to all of us. So what do we need to know? Well, we need to know that there is a process of dying, and we need to know what it looks like. We need to know how it progresses and what its stages are, what the phases of it, and how it progresses over time. We need to understand that symptom management is almost always possible and that we should expect it to be provided. We should not stand aside and say, oh, well, dad's dying, of course he's going to have pain. That is not a good expectation. The right expectation is dad is dying and his pain will be well controlled. So how to get access to help, when to get that help, and how to think about planning ahead, which is something for all of us to contribute to. Whether we're the person, whether we're the family, whether we're the primary care team, secondary care team, tertiary care team, all of us have a role to play in ensuring that somebody has the opportunity to express their wishes, that they're recorded in a way that helps us to provide care that accords to their values rather than just what we can do or what we have in our bag or up our sleeves at the time. So that's the knowledge base. In terms of skills, we need to think about, above all, being skilled in communication, being able to have conversations of immense tenderness that allow people to express their concerns and their love and their thanks and their wishes. We need to be able to sit with people when they express their distress and not belittle it, other it, or try to take it away. We need to sit with it and allow it before we have the temerity to offer to try to assist with it. And people talk all the time about how their families change the subject, how they distract them, how they say, it's not as bad as that, I'm sure you're not going to die. And the moments for those tender conversations are lost. And because we need these things, we need exemplars, we need leaders, we need role models so that people know that it can happen. In terms of attitudes, we need as a society to remember that death is a normal event. It's going to happen to all of us, and that we can prepare for it if we wish. And if we do wish, then we will find that things are likely to run more smoothly during the last parts of our lives. Because let's remember that dying people are mainly living. And dying is a thing that happens on one day, but living is the thing that happens on all the other days, including that one. Enabling people to share information with each other is a very calming thing, and helping families to share an understanding of what's going on helps to bring them together so that they can work together for the benefit of the person that they love who's dying. So let's have a think about normal dying. People are very often surprised when we explain to them that it's a biological process. It's got a series of steps and changes, and it's pretty consistent from one person to the next. The speed may change, but the stages are very familiar. And when you say, you know, birth is a process like that, people say, oh, yes, okay. So because the steps are sequential, a midwife who looks after a woman who's having her particular unique experience of giving birth, that midwife sees how far that woman is through the steps and stages that the midwives are familiar with. Same old, and yet unique on every occasion. And we need to start to think about normal dying in the same way. As we weary towards the end of our lives, people generally lose energy. They need to sleep more, and very worrying for their families, they have less appetite and they're not as thirsty. And we're a nation that shows people that we love them by feeding them. So I've visited homes where forlorn husbands have done their best to take on the cooking and taken what they thought was an absolutely wonderful meal to their beloved spouse, and she wasn't able to eat a thing, and they're both heartbroken for having let each other down. So helping people to understand that appetite loss is a normal part of what's going on is really, really important. On the other hand, sleep is a thing that comes much more easily, but a lot of people try to tough it out, and I'm not going to sleep and I'm not going to give into it. And we need to encourage them to take sleep as medicine, that sleep is their energy aid that recharges their batteries and gives them a little bit more oomph for the next task that they need to undertake. And the next task might be reading the newspaper, it might be chatting to a visitor, it might be being used as a climbing frame by their grandchildren, but they will need sleep to give them the energy that they need to do those things. And what we know is that over this period of gradual onset of inanition, there's a gradual intermittent unconsciousness that these people just don't notice. Human beings don't notice as we become unconscious. They wake up and tell us they've had a good sleep. But we know that a change of consciousness is starting, and that would be the phase where we would start to think about other routes for symptom management drugs, so that somebody wasn't unconscious periodically at a time when a symptom management drug was due, and then by the time they do rouse again, their symptom has come back full force. And then eventually they will settle into continuing unconsciousness as the brain and peripheral organs start to shut down, and eventually just the brainstem is left guarding sentinel, providing respiratory patterns of periodic or brainstem breathing. Very particular type of breathing that we only see in unconsciousness. And at the same time, blood pressure is starting to drop, peripheral perfusion becomes slower, the extremities become cold, fingernails and lips become dusky, I used to notice nurses touching people's noses and wonder why, but now I know the secret about the cold nose and even the cold kneecaps under the bed covers are signs of peripheral shutdown as the person moves onwards towards dying. And then there will be a breath that isn't followed by another breath. It's very unremarkable. Many of us working in palliative care have been into a room where a family is gathered lovingly around a deathbed, and we realize that the person they're sitting around isn't breathing and they haven't noticed yet. It's so unremarkable. And then a few minutes after that last breath, the heart will stop. And that thing about the heart stopping last is absolutely vital for people to understand. This is not a cardiac arrest situation where in a body that's working reasonably well with organs up and running, the heart suddenly stops. This is the heart stopping after everything else has shut down. I think we confuse the public by using DNA CPR wording, DNA CPR orders around end of life. We are in fact the whole approach to discussion of whether or not CPR is appropriate when somebody has just died. But we have many colleagues whose job is not primarily in palliative and end-of-life care, but who are working in urgent care. So here's a token colleague, and this junior doctor is triaging in a local hospital somewhere near you. And as people are brought into the hospital, she is having to discern whether actually this is something that can be sorted out in outpatients or by the primary care team, in which case the person can be sent home, whether they're well enough to sit over there and wait while I deal with the disasters that are happening in another part of the department, or whether you look peaky enough to be told to lie down and I'm going to get some venous access into you and we'll do some bloods and observations just in case you actually go off a bit. Or the person who is distinctly not right, who's going straight into the monitoring bay, venous access established and something running in through it. We'll do the bloods, we'll do the radiology. We're really worried about this person. When you're RMO, it's always really nice to find somebody who can be sent straight away to the surgeons. But sometimes it's so urgent that you want the critical care team to come, or you're even summoned to meet the patient in resus. But there's a diagnosis that is missing from this set of diagnoses. And I made this slide for the Society of Acute Medicine meeting last year in response to a document that they had produced, which talked about patient flows through the emergency room and failed to mention death as one of the possible outcomes. Because actually, this is the rider for anybody who is so sick that they're brought into a hospital, or so sick that they could be in hospital but elect to stay at home. And this person is on the wait in all of these different guises across this patient's possible trajectory. So we have to be able to name that dying is one of the possibilities that might happen here, and we need some language to talk about that. Because for our colleagues in acute medicine, very often what they're doing is dealing not with a certainty that somebody is dying, but with an uncertainty because somebody is sick enough that they might die, but is still being treated with resuscitative intent. And this is a really important part of the conversation about medicine and about death. For this person who arrives in hospital unstable, or for those of us who are out visiting a person out of hours in their own home in residential care, who's suddenly become much less well, what is the diagnosis? What is going on? And what is it that's making this person so very sick? Is there any part of this that's reversible? And how reversible is reversible? And this is a really important question, because what we're asking is, could there be an outcome here for this person that's actually worse than them dying? And we will only know that if we know what their wishes and values are. So these are the sorts of things that we need to be asking of the person and their family. What does this patient know, and what are their wishes? And how much disability would this person be prepared to tolerate if we can snatch them back now from the jaws of death? What's more important to this person? Do they want length of survival above all? Or is it about the quality of that survival? Does that matter more? And these are really important things. And these are things that change over time. They change over a lifetime. They change depending on what events are on our horizon at the time. And so this isn't a single conversation. This is a series of conversations every time we meet a patient. What is it that matters most? How do we make sure that the care you have matches the values that you hold? So we need to be encouraging people who are reviewing patients who are acutely unwell to ask themselves whether death is a possible outcome here. And if it is, what would dying well look like for this person in these circumstances? So that we can begin parallel planning. We can continue with the restorative treatment, but we're offering end-of-life care at the same time, just in case. And one of the things that I think is really important here is if a person needs to be calmed in order to be transferred safely or put in a scanner safely, for example, we will use sometimes temporary sedation. And the intention is that it's temporary sedation, but for somebody who's critically ill, this may be the last time that they're awake enough to speak to their beloveds. And we need to think, we need to ask, do we need a pause before we give this drug in order for them to say those important things, in case this is the last conversation they're ever going to have. So the sorts of phrases that we need to be offering to our colleagues who are working in acute medicine is to encourage them to help patients who wish to have the conversations and their beloveds to understand that this individual is so sick that they could die. Now, it might be so bold as sick enough to die. It might be slightly more subtle than that. I'm sorry to say that I think your dad might not be strong enough to survive the night. I would advise you to stay in the hospital because I'm not sure whether or not we can save your wife's life. She may now be dying. What would we wish we had done tomorrow if this person you love is even more sick than this? What would we wish we'd done tomorrow if this person dies overnight? In case we can't reverse this, shall we do those things now? And then, what do you know about dying? What are you expecting to happen? Can we demystify the process so that you can know what the sequence of events is that we are going to be looking out for as well? What we're talking about here is dying safely. And there's an awful lot of fuss about the way we die and the place we die. And we've decided as a nation that the really important piece of data we'll collect is place of death. But actually, we know from very good research that by the time people are approaching the end of life, the place isn't nearly as important as the people and being treated as a person oneself. At the very end of life, it's having our beloveds around us that matters, and they can create a safe space around us in a 6-bedded bay in an acute medical ward if that's what's required. We need access to good symptom control so that we are not distracted from thinking as clearly as is still possible for us by difficult symptoms. And during COVID, we've learned a whole new way of creating community around a person who is only allowed one visitor or 2 visitors instead of the whole family gathering around the deathbed. So we're learning even now about how we can help people to be together at the end of somebody's life, even when they're physically separated. So how are we, who are the community for enabling this kind of change, how are we going to do that? Certainly we can't keep doing it a single family at a time, can we? Which has been the way that we have been approaching it. This actually is a public health issue that requires a massive change in public understanding. And we can't do that alone from palliative care, and we can't do that alone from medicine. This is about a societal thing. I suspect it doesn't need a lot of funding, it doesn't need huge strategies, it needs leadership and it needs political will. If we simply actioned the ambitions framework across Britain, we would have made a huge amount of progress. But what we need to do is to capture the public imagination. And we won't capture the public imagination with data and audits and research. I'm sorry, I know this is the Marie Curie Research Department seminar, but actually the thing that captures people's hearts is stories. And we have to be able to weave our research outcomes into stories that capture people's hearts for them to want to get behind any form of change. And we've all got stories to tell. So I was absolutely incensed when I discovered that the BBC, the British Broadcasting Corporation, in the land of Cicely Saunders, had invited an American surgeon to speak about end-of-life care for the Wreath Lectures series a few years ago. And then I heard his first lecture. I was driving between the hospital and the hospice where I worked at the time. It was so compelling, I had to stop the car. This man is an orator, but this man is a storyteller. And the story that Atul Gawande tells of discovering what palliative care is really about, and discovering that actually it's more about being than doing, and it's about discovering what matters most to individuals, and how he as a surgeon then applied those principles when his own beloved physician father was terminally ill, is an absolutely humbling read. And if you haven't read it, I suppose a lot of you have done, I absolutely commend it to you. So now I understood why Atul Gawande was giving the Wreath Lectures about end-of-life care. And it was reading Being Mortal that made me realise that the notes that I'd been making for my own mental health throughout my career, writing patients out of my head and onto a sheet of A4 paper with no names on anywhere, could be the basis of telling stories that would enable me to take people to the bedsides of dying people and just sit with them there and look at what's going on. And now we've been joined by other writers, so our friend and colleague Rachel Clark's beautiful book, Dear Life, which again is storytelling about end of life. There are two wonderful books now by Christy Watson about nursing, as well as her novels. But actually, we're all new kids on the block compared with this guy. So Sherwin B. Newland wrote his wonderful book, How We Die, in the early 1990s, another American surgeon taking chapter by chapter a different story and then examining the physiological process behind the way a person has died of a stroke, of a heart attack, of a stabbing, all sorts of different causes of death, absolutely beautifully examined. And by telling stories, what we're able to do is communicate with people in a different way. We need those stories. They need to be true stories. They need to be taken from life, and they need to be told well. They have to be in formats that people access and from different sources. We need stories in soap operas, in magazine articles, in podcasts and webinars, on the internet, on paper. Just the truth over and over again about ordinary dying, normal dying, until everybody knows, but nobody remembers how they know, because that's how it was when people were familiar with that wisdom. I particularly think we need to think about how our soap operas manage end of life, and they have been guilty of hijacking stories simply to get viewing figures. Coronation Street did an absolutely wonderful story last year with a lot of palliative care support for the writing of the storyline of a young mum dying of cancer. I thought it was very funny that during the episode during which she died, there were conversations about dying, conversations about how dying happens, conversations between people revealing their inner hearts. And I knew this was happening. I was actually not at home and not watching the television, but I got texts all evening saying, "Did you write this?" Because it sounded like text from my book. But it only sounded like text from my book because I was describing ordinary dying and they were portraying ordinary dying. And guess what? They're the same, and it matched. So Coronation Street did us a great service last year. In Peru, I visited Peru for a book festival last year, and they were struggling with not having enough donors for organ transplantation. And the government asked their two most popular soap operas to include kidney transplant stories in their storylines over the end of 2018 and early 2019. And the result of that was, by the time I was there about this time last year, they had trebled the donation rate for organ donation in Peru. The soap operas are very, very powerful, and we need to think about how to get our information and our stories out to people in ways that they will take in and assimilate. So I'm going to wind up now, because I think it's going to be much more interesting for us to talk to each other than for you to just sit and listen to me. So I'm going to finish by saying I feel there is a wisdom that's forgotten, that it is time to reclaim it. And tonight, this is an audience of people who have the potential to lead the way. What are you going to do? What can you do tomorrow? And what else can you add to that next week? And what could you do next month that will change the way we think about and talk about dying in this country? I'm really interested to hear what you've got to say. Thank you so much for inviting me. I'm still completely amazed at what's happened since I wrote this book, and entirely grateful to all of you. I've seen lots of names here of people who've been so supportive during this campaign. Thank you all very, very much.
Thank you, Kathryn. That was so good. And I love the way it's forgotten wisdom, but never been written down necessarily before the 1990s. Perhaps I should go through the chat and then we can open out the questions. So the chat, firstly, people were asking about your slides and whether the recording is going to be accessible. It will be on the Marie Curie UCL website, both your slides and this recording. So Alex Wright would say she was wondering about what your views are on positive and negative language in these situations, of, i.e. dying versus not surviving. I suppose it's slightly out of context.
I think that's a really good question. We're trying to persuade people to have conversations, clinicians, to have honest conversations that make them uncomfortable. And we have to think about, why does it make them uncomfortable, first of all? It makes them uncomfortable because somehow they think that when they give the news to this person and the person who's understood the news gets upset, which is entirely an appropriate response to the news they've just been given, that they have upset the person, that they are guilty of upsetting the person, rather than, if you break bad news well, the news itself causes distress and you are their companion in distress. So we need to think about how we teach those communication skills. But certainly during COVID, when people were needing to make heartbreaking phone calls repeatedly in a single shift to talk to the families of all of the people on a COVID ward who were deteriorating over that day, it might have just been too difficult to be saying the words dying, dying, dying. Can we just ask everybody to make sure you're muted, please? We just might need to think about using different language. So not surviving, I don't think he's going to make it, and then qualify that. As everybody who knows me knows, I'm a fan of the D words. But sometimes it's too brutal, and saying nothing is worse than using positive language. So I think go for what works, but just make sure that what you say isn't ambiguous. Check understanding afterwards. It's the usual rules of engagement in communicating.
We have 14 more messages, but I wonder whether Alex would like to unmute herself and add anything she wants to reply. Don't worry if you don't.
That was really useful.
Oh. Great. We just about hear you. It broke up a little bit. So another person says that the Reef lectures are still available on the BBC Sounds archive. Other people are giving recommendations. Good Life, Good Death, Good Grief is a helpful online tool.
I don't know whether people know Good Life, Good Death, Good Grief, but it's the Scottish Partnerships Agency for Palliative and End-of-Life Care website, and it's absolutely fantastic. Very, very well worthwhile perusing.
Kate Tomlinson asks, if you want to write about people who are dying, how do you get their consent?
That's very interesting. And the answer is, of course, if they're dead, you can't. So I suspect if I was starting now, if it occurred to me that actually writing about these people would be an interesting idea, I would approach them for consent. But what I had to do was to think very carefully about whether it's the right thing to do at all to tell those stories. So what I felt was that this is in the public's interest. It's a public education problem. And the only way I could write would be honestly from experience. I took great care then to change enough details in every story that people wouldn't be recognizable. I changed all sorts of things about the people themselves and their family structures and their backgrounds. Some stories are actually composites of several different people woven into a single person's story. So everything in the book happened, but it didn't necessarily happen to the same person that another thing had happened to. That left me with 6 stories where I couldn't anonymize them enough that they wouldn't be recognizable on publication, and I had to go and find those families. And that some of them were from very, very long ago. I had no names on the pieces of paper. One of them was a family that I'd actually looked after over periods of time across my career, so I knew their name and I was able to track them down. I tracked all of them down but one family, and everybody was just enthusiastic. Everybody said, yes, please do this. We wish there'd been something like this when we needed it. They saw the story in case they wanted to take anything that was personal to them out of it. There's only 2 stories that use actual people's names, and those families asked that their real names should be used. And there's one wonderful story that I'm not able to tell because I can't track the family down. So I've been very careful. I've discussed it with our local clinical ethics advisory group, because the GMC guidance about anonymizing patient stories for education is all about professional education. There's actually nothing about public education in GMC guidelines. So I've tried to be as ethical as I could be about it, but I admit that I feel a pang that I have broken what was the assumed confidence contract between me and those people.
Okay. Nicola, do you want to see if you identified?
Yeah, so there's a message from Natasha, and she's asked about how do you manage different cultural expectations of death, particularly when in some cultures there's no worse outcome than death.
Yeah, and that's absolutely true. So the question is, could there be a worse outcome than death for this person? Well, how do I find that out? I have to talk to this person, and I have to talk to people who know this person and what their wishes and values are. So it's very, very hard to see the goggles that we wear that stop us from understanding somebody else's perspective. When we think we've done our absolute best to be culturally sensitive, we still will be making mistakes if we're outside our own culture. And I think the absolutely best way to approach this is to acknowledge that there's a cultural difference and say to the patient and the family, we want to get this right for you, and there might be parts of this that we will get wrong by mistake. Please tell us, please help us, please assume we're trying, and please feel free to tell us when it's wrong so that we can put it right. And I don't think there's any other way of doing it.
Another person, Alice Harper says, what would your advice be for junior doctors having conversations with families re shift in management, i.e. stopping IV antibiotics and fluids, sorry.
Okay, so this is a conversation which is about recognizing the diminishing returns of interventions, isn't it? And I think that this is a conversation that needs to be part of this family understanding their beloved person's story. So I would start that conversation by, first of all, the usual introductions, checking who you're talking to, checking whether you've got permission to talk. But I would start by asking them to explain how things have been for this person that they love over the last few years, and then over the last few months, and then over the last few weeks, and what patterns they see in that. And that helps me to understand what they understand. It helps me to understand the kind of language that they use for describing it. It also helps me to know if they've misunderstood any things, so we can sort those misunderstandings out before we build some more things that might be misunderstood because they're built on a misunderstanding. But the other really important part of that is, as that person tells the story, they themselves start to hear, yes, that actually over the last few weeks, this person hasn't been nearly so well as they were over the past few months, which was itself a change from a year ago. Or they might be saying, actually, this person that you see lying in a bed here looking 3 parts dead, doctor, was doing whole rounds of golf 2 weeks ago, in which case actually my understanding needs to be rejigged, right? So we're starting off with questions, not statements, and what we're doing is ascertaining what the arc of the story to this point has been. So now we can start to think about whether the treatments that we've got, that we give in this ward, in this hospice, that we bring to this care home, although we can do them, are they going to be beneficial for this person who you love? Are they going to help them to have the kind of life with the kind of values that they want to have? So now when they say, well, actually, there's a grandchild due to be born in 10 days' time, that's a conversation changer compared with, actually, do you know what? He's just been so sick of his life for such a long time now. It almost feels cruel to do things to him. So we're actually now starting a conversation that isn't me telling you we're not going to do things. It's me wondering with genuine curiosity whether he would approve, she would approve of the things that we can do. So what we're doing is helping families to help us understand whether this person would agree or disagree to a treatment that is appropriate, or even to work out whether they would consider it appropriate in the first place. So by the end of the conversation, we might not have reached an agreement, but what we've done is a journey together where we've noticed how this person is compared with how they've been. And it might be that the next conversation, which might be with my colleague who comes in to relieve me on the next shift, is the conversation that moves towards the things that we might not start, or the things that we've started that we might discontinue. These are conversations, it's a process, it's not an event, and it is really difficult. And my other advice for all junior doctors is watch people who are senior doing it. Some of them will do it magnificently. Work out what it is they do and notice what it is that they do. They probably ask more questions than they make statements, for example. You can learn a lot from watching people doing it badly too. That's okay. And they're doing their best. We won't be critical that they've done it badly. We will sit and reflect on what it was that they did that you think maybe you could have done a different way. But never assume it's easy. When you see somebody doing it badly, it's possibly not because they lack skill, it's because the circumstances are really difficult.
Very good answer. Nicola, do you want to do the next one?
Yeah. So there's one from Vic who's asking about combative language. So things like she's a fighter, and that she struggled to explain to people that there's going to come a point when death is going to happen. So what's your take on the use of language?
The combative language, and President Trump, who got better from COVID because he's a fighter. Thanks for that, Donnie. It's a really important part of the family's story. The family has this story about this person has this character, and the character is that they're a fighter. Oh, so your mum's a fighter. Tell me about her being a fighter. Tell me what things she's fought for. Tell me about the battles she's had. Tell me about the battles she's won. Wow, she is a fighter, isn't she? What's she been fighting for? She's been fighting to have time with you, to be your mum, to have that relationship. That's all really, really precious. What do you think she will want to do when the time comes that she's too tired to fight? What do you think she'll want to do when there's just no bullets left to fire? Why don't you just sit with them in their fighty language and just talk about how it might feel to relax at the end of a fight and sit down and just let things be? So if we say we don't like that language, we immediately confront them. So join them in their story, and then help them to weave it into a place where this fighter can be thanked for their enormous effort and be allowed to graciously put down their arms. The Japanese have a ceremony where it's called discharging their loyal soldier. A lot of Japanese soldiers who had been fighting in the Pacific part of the Second World War didn't even know the war was over. They had to be gradually found and brought back, and they came back to find that their empire had submitted. They could not believe the indignity that the emperor had signed a submission treaty. And they came back to their villages and they didn't know how to be. And the very wise elders in Japan realized that a ceremony was required. And so an edict went out to the mayors of all of the villages to say, your village must discharge their soldiers on behalf of the emperor with great grace. You have to hold a ceremony. Everybody must applaud the soldiers for the effort that they have made. And you must now thank them and tell them that the time has come to discharge them as a loyal soldier, because the emperor now needs them to be a fisherman, a farmer, a market trader, whatever their job was. So rather than saying, no, we're not doing that anymore, we're saying that was hugely valuable, and now it's time to move on to this. I think it's a really fantastic story.
Great. Shall I go? Or there's a question from Iski Gordon. She says, the medical profession have become fixed on a DNA CPR. Yet this is almost a tick box event. It is often called ACP. There is no or very little conversation. How can we persuade our colleagues that DNA CPR is inappropriate on its own, especially in care homes?
I think that's a really, really great question. And you know what would make a huge difference would be if we move from a model of saying what we're not going to do. We're not going to give antibiotics. We're not going to do CPR. We're not going to admit to hospital, to saying what we are going to do. So we have anticipatory care plans that say, okay, so this person who has a brain tumor, as they progress with their illness, what they want, what matters most to them is being in a place that's familiar to them and being safe if they have seizures. So we know the seizures are likely to become more often. This is the plan for if they have a seizure. So now, if I'm the doctor on call for the weekend, if I'm the paramedic who attends the 999 call because the seizures haven't stopped after a couple of minutes, I come in and I've got a plan that says, if this person has prolonged seizures, do this and then this and then this. They like to be called this name. They want to stay in this place. Please only admit to hospital if something that's outside of the breadth of this plan has happened. Because once we start to talk about what people should do instead of what they shouldn't do, we allow people to step up and act and continue that safety net around the person. If we just say, well, don't do CPR, well, they didn't need CPR anyway, they're having a fit. What's the thing that they need? So yes, I think it's a really unfortunate thing that's happened, that we've got so torn about cardiopulmonary resuscitation decisions that we've forgotten about quality of life. And I also think it's been very difficult that the media have got hold of the expression advanced care planning and misconstrued it to mean only CPR decisions, rather than the richness of who this person is, how they want to live, who matters to them, who should be round there, whether they want talk radio or music radio on around them, that they hate rhubarb. These are all really, really important things about people. And then there's a tiny little bit of it that's the medical decision making. That's not advanced care planning. That's advanced medical decision making. And it's a tiny, tiny bit of a really rich conversation that we should be having.
Great. Yes, so Moira said a similar question to that, so that wasn't the only one that referred to that topic.
Yeah, there are a couple of questions about COVID and how you think that has impacted dying. What your thoughts on that are?
Oh, that's probably the most massive question in the world, isn't it? So first of all, I retired from clinical practice a few years ago now to do this campaigning work. And then all of us who come off the register in the last, I think it was 3 years, were emailed by the GMC to say, unless you say no, we're going to put you back on the register with a license to practice. Hooray. So I went back to my big local trust to see what I could do that would be useful. So during our first surge of COVID, I was embedded in a clinical psychology team working on staff support. And what we discovered fairly early on was people were very anxious about those conversations, particularly by phone, or if they were trying to break bad news and they were masked and gowned and all the rest of it. So running communication skills training. That's a long way of saying I haven't done bedside work during COVID, but I've heard the feedback of a whole massive workforce of people who are engaged in the bedside work. I think we learned lots and lots of things. We've learned as a population that people die. We've learned that fit people die. We've learned that people die even with the best technical care possible. And that's really smashed some of our cultural myths about the potency of medicine. And although that's been heartbreaking for the individual families where that's happened, I think it's probably been really helpful for us to start to think about ourselves again as people who are mortal. I think we've learned a lot about how we can help people to be joined up despite the fact that they're separated from each other. I think what's quite funny is that we think that we've recently discovered about screen communication so that we can help a family only 5 streets away, but they're not allowed to visit the hospital to visit a person who's in hospital using a screen. But I suspect that families have been around deathbeds for as long as we've had Skype or WhatsApp video or whatever, chatting to each other from Brighton to Bolivia or Australia to say, look, I'm going to show you Dad now. He looks really pale and his breathing's a bit funny, but here you are, can you see? Holding the phone up and letting them see. Families have been using this technology for a long time, and we are late to this party as healthcare providers. We then had a horrified phase of by starting off. So we've done the same thing we do with all medical interventions. So the first phase is, this is the best thing since sliced bread. Let's buy tablets for every single ward in the hospital. Let's have volunteers who are manning the tablets. Let's make sure that everybody can have video calls. Then the pendulum swings to, oh, this is absolutely terrible. People are having video calls and they're videoing the last breaths of people. We can't allow that. That's absolutely terrible. And then we're swinging into the middle where we're saying, actually, do you know what? We always have people present at the last breaths. The really important thing was that we had somebody with them explaining what was going on. And that's what we still need to be doing on a video phone to say, I'm going to take you into your mum's room now in the intensive care unit. You'll see she's lying on her front because that's helping us get oxygen into her lungs. You'll see the tube that's connected to her ventilator. I'm going to put you right by her ear. So say the things that you want to say. Let her hear your voice. I don't know whether she'll understand, but she may very well hear your voice and recognize you. Tell me if there are special messages you want me to give at the end of this phone call. I'm going to take the phone backwards now so you can see her lying there. You can see the room that she's in. So you've got a picture in your head of how things have been for your mum. And in another 20 minutes, we're going to turn her over and she'll be back on her front again. Because if mum is going to survive, then it's really important that the family can help mum to put the jigsaw of what on earth happened to her together afterwards. If mum is going to die, it's really important that the family can put together the jigsaw of mum's last journey, which is what we compose around a deathbed to tell and to comfort ourselves in our bereavement journey. And so I think what COVID's really shown us is how very, very important that continuity of understanding day by day, minute by minute, what has happened to this person that I loved who died, so that I can make sense of it and bear it in my bereavement. And what COVID has really shown us is how traumatic it is not to be able to be with or know about what's happening to a person as they die. So I think it's been a game changer.
There's questions in regards to training students that communication skills, like there's a very small window of opportunity to support this important area in communication and student learning.
That's interesting, isn't it? It is really important that we teach communication skills. It is really interesting that I've had lots and lots of communication from nurses in particular who say, I was at my first death today. I didn't know what to say. And actually, when you get back and talk to those people, what you discover is by I didn't know what to say, what they mean is I didn't know how to be. And I think when we're doing presence at the deathbed training, and I learned this from nurses, not from doctors, thank you nurses everywhere, it isn't about what we do, it is about how we conduct ourselves. It's how to be present, how to be calm, how to be quiet, how to check that the right people are in the right places in the room. The terrified spouse sitting in the far corner needs to be brought to a chair by the shoulder. They need to be shown how to hold a hand. They need to be helped to be present. They need to be given permission to speak. The next door neighbour who brought the terrified spouse in, who's an accomplished hospital visitor, sitting in the big chair by the bed, absolutely in the way of the sorrowing family, needs to be given a cup of tea in sister's office. We need to sculpt this so that people are able to be around the bed, and our students need to see that that's what we're doing. I encourage medical students in their final year to adopt a dying patient and to call on them each morning to see how they've been, how their night has been. By the time the family keeping vigil, ask the family how it's been. Have you all had a chance to have breakfast? Do you want to go and get a cup of coffee and I could sit for a while? Because they need to learn how to be, and their stethoscope is no good to them at this point. There are no doctory things to do. It's about being a companion, and it's about having learned all that clever stuff that gets you through medical school or nursing school. This isn't clever. This is intimate and gentle and personal, and it's not about saying the right thing. It's about being there with the right attitude. Don't know whether that answered the question.
I think it gave a lot of information, very important information. We have reached an hour, so I think we've covered a lot of the themes of the questions. I'm not certain whether we can forward this chat to you or we can save it, but we'll see. I've never done this before. But anyway, I would like to thank everybody for attending and to thank Kathryn. Our PA, Jana, will be sending evaluation forms and should be sending everybody a link to the website so we can listen to you again and look at your slides again, Kathryn. And just to say, before we all clap our hands and thank Kathryn, that our next webinar currently is aimed for next February. It seems quite a long way away, and that's Professor Dame Fallowfield, who will be talking about communication or prognosis in advanced stage cancer. So perhaps, as well as there's a lot of thank yous coming in, I can see. Yes, there's loads of thank yous coming in. I'd just like, perhaps we could unmute ourselves and give you a clap.
Thank you.
Thank you. Thank you, everybody.
Thank you.
Thank you.
Thank
Thank
you.
Thank you all very much.
Thank you.
Thank you.
Thank you.
Bye.
Thank you.
Bye, Kathryn.
Bye, thank you.
See, she said it to me.
Thank you.
Thank you. Thank you.
Thank you.
Gosh, so many lovely comments there.
Thank you.
That's
Fantastic.
lovely. Thank you all.
Thanks.
Thank you.
Yes, I was a bit worried it was getting a bit, your reception was going against. Oh my goodness. But
Oh no, was it? So was my voice going a bit wobbly?
a little bit, yes.
Oh no, I'm so sorry. This hasn't happened before.
And stop recording now, can't I?
Yeah. So I'm not certain in the recording whether the chat's saved. So
It's just how it is cloud recording.